welcome to Merced College Nursing. My name is Kitty Cazares. I'm the RN Program Director and CNA Program Director here at the college.
And my name is Dr. Wanda Schindler, and I am a first semester instructor here at the college.
So we have some things that we're going to share with you today. I'm going to start off by giving you some information about our nursing programs that we have, kind of tell you about the length of time, how to get into the program, and the roles that they serve. I'm going to start off with our CNA program, which is Certified Nursing Assistant. It is a one-semester class, usually goes for 18 weeks. It has a 3.5-hour lecture week and a 7.5-hour clinical day. There are no prerequisites to get into the CNA program. We can take students that are in high school. They have to be at least a junior and 16 years of age. Once they finish that course, they are eligible to sit for the state licensing exam. Most CNAs work in long-term care. They can do home care. The CNA's role is really about activities of daily living. And if I asked you what activities of daily living, of course thinking about like when you get up in the morning, how you start your day, just getting up from bed, getting dressed, brushing your teeth, being able to feed yourself, if you're able to walk, all of those things that we take for granted, people that are usually in long-term care need some assistance, and that is what a CNA is qualified to assist in all those activities. The pay for CNA in this area is probably about $10 to $12 an hour minimum wage, but there is great opportunities to work in different environments, to be able to work with people, and if you think that any other level of nursing is something you want to do, this is a great way to start. Here at the college, we also have a vocational nursing or licensed vocational nursing. It is a 3-semester program. We take one class every 3 semesters. So we had a class that just started. That class will graduate in December of 2021. So we'll have another class starting in January 2022. The prerequisites to that program are the basic anatomy, the one without a lab, nutrition, medical terminology, and pharmacology math. So once you've completed those prerequisites, you go online, you get the application and fill it out, and you're able to submit your name into the wait list. We have suspended the wait list with COVID. Normally we run about 100 to 125 people on the list, and we're only able to take 40 students every time we start a class. So if you went on the list today, chances are it would be 3 years before you could start the LVN program. LVNs are able to do a lot of things that a registered nurse can. Of course, they can do everything that a CNA can, doing all the activities of daily living. They also can pass medications. They can do basic data collection with a patient, like listening to lung sounds and bowel sounds and checking pulses. They typically work in long-term care. They can work in jails, doing home care. We do have a very limited amount in the hospital, and their typical pay in this area starts at about $20 an hour. If you go work in the jails and the prisons, you can make $30 to $35 an hour. So they make quite a bit of difference in those areas. I'm trying to think. We have a really excellent program. The pass rate for our LVN program is pretty high, usually over 90% pass rate once they finish our program. And then finally, the last one I'll talk about is our registered nursing program. Of course, that's the one that we have the most demand for. We take 27 students in the fall and 27 students in the spring. The reason that we don't go ahead and fill that class up to our 30 max is because we do take LVN to RNs into the 3rd semester. And so we usually have graduating classes of 29 or 30 students. The prerequisites to go into the RN program are the anatomy with the lab, microbiology, physiology, English 1A, and Math C, which is intermediate algebra or something higher. You have to have a 2.5 GPA in that, and also you have to pass the TEAS test, which is a type of an assessment test that is administered by a nationwide company that is approved by the California Board of Registered Nursing and the Chancellor's Office. We do only accept the first-time passing score on that, which is a 62. That number is set by the Chancellor's Office. The passing the TEAS test is a predictor of the likelihood of success in an RN program. Once you have got your 2.5 GPA in those 5 courses and you have your passing TEAS, when we take applications in the spring, you can apply, and then we have a selection process that does have a lottery component and a points component. Our next application will be taking 30% of the slots, which is a total of 54 for the year, will be by points, and then 70% by lottery. The next year it'll be 40, 60, and then finally in 2023 application, I think is what it was, it'll be 50% by points and 50% by lottery. We normally get at least 4 or 5 times the number of applications versus the amount of spots available. And so we do encourage people to apply to multiple nursing programs wherever you're willing to drive, because it is a challenge to get through the lottery process. So we're going to start by Dr. Schindler is going to show us some of the toys that we have. And
so we have 3 pieces of equipment here that we're going to discuss. The first one is an oximeter. It looks like this. This is a portable type in the hospital. They actually have them on larger monitors or larger machines. But anyway, what this does is it's just as easy as placing it on a finger, and it tells the oxygen level in the blood. Okay, so basically what you do is stick the finger in and turn it on. Some of them actually, as soon as the finger goes in, they automatically come on. You place your finger in, and actually it's this way. So what it does is it tells the person's oxygen level, which normal oxygen level should be above 95% to 100%. Anything below that is something that is more abnormal, okay? So the person's not oxygenating their body very well. Another thing that's on here is the pulse. And so basically what this does is it picks up the pulse. Once it picks up the pulse, then it gives the oxygen saturation percentage. And this actually keeps turning off on me, but that way you can see what mine is. It shows 96%, which is normal. So I'm breathing and oxygenating my body well enough. So some of the times that these are used, and some types of patients these are used more on, or maybe a patient that has pneumonia. They come into the hospital and they're very sick, and they have like a bacteria in their lungs, and they're not oxygenating their body very well, and so this is something that's monitored, along with maybe an older person or a person who has maybe a chronic lung disease, and those are another type of patient that we would monitor their oxygen level on as well. Some of those patients might have oxygen percentages at 90%. A lot of their baselines are more at a lower level than at a higher level. And that's pretty much it with that. The next piece of equipment we have here is a Doppler. It's a pulse Doppler, and this is used when, say, a person's pulse, whether it be a radial pulse or a pulse somewhere else in the body, is very faint, and just by feeling for it or palpating for it, it can't be felt or palpated, or maybe we're listening with a stethoscope and we can't hear it. And so basically what happens with this is this gel, that's pretty loud. This gel is placed, and I'll put it on myself on my radial pulse. The volume is loud enough where you should be able to hear it. So this is my pulse on my arm, okay? And this way, once again, if a patient has a pulse that you can't palpate or listen to with a stethoscope, then this is a machine that we use to where we can pick up that pulse.
And then if you've seen anybody that's had a OB appointment, of course, we can actually use this to pick up a fetal pulse rate, right? And so, and you can hear that kind of whoosh, whoosh sound, and that literally is the sound of the blood pulsating through her veins. And then the final thing that we're going to show you in this segment is, this is called a vein finder. There's all kinds of different companies that make them. They all maybe look a little different. This one, we just use it as an example. This particular one, it doesn't look like a whole lot of equipment, but this is $2,000 is what it costs to buy. And so sometimes people are very difficult to find their veins. Obviously, Dr. Schindler's got some nice veins there. But if we were having trouble and we needed to start an IV, that we can actually use this, and you can see how well that it shows all those veins, so that if it was a difficult one, we could actually see the ones that were larger in diameter versus the ones that maybe have a narrowing, and we think, oh, that's maybe not a good place to go. Have her turn her hand, and of course she has them. And you can see how large those veins appeared in the back of her hand. So these are just some of the equipment. For our next segment, we're going to go and introduce you to our simulation mannequin.
So we're in the ER here, and we have a patient that came in with some shortness of breath. Patient had been a smoker for several years and has a chronic lung disease and has developed pneumonia. And so the patient started feeling a little short of breath approximately 4 or 5 hours ago, and came to the ER. Once this patient comes into the ER and they're short of breath, as nurses, one of the things that we do is we put them we put them in bed. We usually put oxygen on them, and then we put them maybe on a heart monitor. As you can see, this particular patient is attached to a heart monitor, and what the heart monitor is telling us is it's telling us a couple of things. It's telling us the patient's heart rate, is it regular or not regular? It's also telling us the oxygen saturation. We had spoke about the oximeter before. This particular patient has it on his thumb. It is attached to a monitor, so you can see that it's his oxygen level right now is 90%, and as we said earlier, 95 and above is normal. So that's telling us as nurses this patient's lung sounds or their oxygenation isn't as well as it should be. And also another thing that the monitor and that we usually do is we usually take their blood pressure and their vital signs, temperature and all that. This patient, one of the things that I noticed about this patient is the fact that they are breathing, and they're breathing a little bit more on the rapid side compared to maybe normal respirations, which normal respirations would be breathing between 12 and 20 breaths per minute. And this patient's breathing at around 24 breaths per minute. Another thing is we use stethoscopes here to listen to lung sounds. And so one of the things that we do is we actually listen anteriorly, which is the front portion of the chest, and we also listen to the back, which is posterior. This patient has been exhibiting wheezes. And what are wheezes? Wheezes are like a musical sound. They're like a little whistle. And so he actually has very audible wheezes throughout his lung sounds. And so basically with the oxygen, and then maybe another thing that we might look at as far as this patient is maybe starting them on some type of antibiotic to help with that pneumonia they have, and getting cultures, respiratory cultures, to see what kind of antibiotic the patient might need. So here at Merced College in our nursing program, we have a high fidelity simulator, and that's who this gentleman is right here. This simulator simulates different situations that students can, or instructors can have students go through to help promote their knowledge a little bit more in a pretty calm environment compared to what a hospital environment might be. This simulator does lots of things. As you can see right now, he is breathing. He can make sounds, like for an example, 1 second. It's not. For some reason, I'm having a problem with this kitty.
They hit that play button?
Yeah, but it's not. So this is him coughing. And so when a patient comes into the hospital and they have a cough like that, some of the things that nurses need to do, part of the assessment is to determine what kind of cough is this? Was this a productive cough? What is a productive cough? It's when someone coughs and they're coughing something out, okay? And when they do cough stuff, whether they cough it totally out or it's just there to where they can't cough it out and you can hear it, is one of the things that we as nurses need to do is determine, you know, what color is it? Is it thick? How much are they coughing out? Or could they have a cough that's a dry cough? It's a dry, hacky cough, not anything that there's not any mucus in there. Each time, each one of those types of cough actually tell us a different story about the patient, you know. Like for an example, I mentioned pneumonia earlier. A patient who comes in with pneumonia more than likely will have a productive cough. Maybe a patient that has a chronic lung disease from maybe smoking for many years, they may have a cough that might be more dry and hacky. So that's part of our assessment as a nurse. Another thing too is you might have a patient that may just you know, start moaning or whatever, and it's up to you as the nurse to determine what is it that this patient might need. And then other things that this mannequin does that will allow you to assess the patient would be something like this. And what do you think this is? For those of you who said seizures or convulsions, that's correct. So this patient is having seizures. Some of the things that we need to do as far as nurses to care for patients that have seizures is make their environment safe, because they are to a point to where they can't take care of themselves. We as nurses take care of them. And maybe.
So now that you've seen just a little of what our high fidelity mannequin can do, I'll talk a little about how we're able to purchase a lot of the things that help support our program. We receive money from the Chancellor's Office. This simulation mannequin was about a total of $135,000. $35,000 of it is just in the extended warranty to make sure all his parts keep operating. We also have a sim mom. The simulation mannequin, the mom actually pushes out a simulation baby. It actually has to where, you know, you gotta lube up the baby, and we'll actually show what it looks like with a delivery. You can put fluids in it to where it actually looks like it delivers, you know, blood afterward, the placenta. So they're very, very realistic. This particular model, he's got pulses that you can feel, pedal pulses. If we wanted to start an IV on him, we could actually put fluid to where it looked like he had fluid return, it looks like blood. If we were going to put a catheter in to drain urine from the bladder, we could actually put yellow food coloring to look like there's a drainage of urine there. He is actually, we could take the scenario that Dr. Schindler was just talking about, and we could talk about that eventually his respirations become even more labored. And all of a sudden his O2 saturations drop below into the 80s, and now we have to worry about whether or not he's getting enough oxygen to even supply the heart with it. And then all of a sudden now we've got cardiac issues. So we can take this patient, keep having him decline to the point where we have to code him. This particular model allows us to where we could intubate him. We could, you know, make him look like his eyes close all of a sudden and he's losing consciousness. He'll get a blue color light around his lips, and to where it looks very realistic that he's now in complete respiratory distress. The beauty, of course, of having a simulation mannequin is we can take and watch things go bad, and then, of course, if this patient dies, all we gotta do is turn him on again and reset, and he's alive and well to go. So we can record the sessions, we can then debrief and be able to say, okay, what things went well, and what should we maybe have different interventions there. And it's really an excellent way to be able to learn. We also have a pediatric simulation mannequin because his size is smaller and doesn't have all the mechanical components in it. He doesn't have the chest rising as this mannequin does. He doesn't have all the pulses. If we put him into a seizure, only his head moves. But it's a nice way to where we can actually get students prepared to go to Children's Hospital, which is where we do our pediatric rotations. So one thing I didn't share earlier about our nursing programs, especially our LVN and RN programs, By the time students go through the whole program, where it's the 3 semesters in the LVN or the 4 semesters in the RN, they get to go to areas like the operating room, they go to the pediatric rotation, they go to a psych mental health rotation, both at the inpatient and the acute care. They go through OB, so they get to watch those babies being delivered, and then of course postpartum. They spend a lot of time on the medical surgical floors, going into telemetry. The RNs actually get to go into the ICU, and both nursing programs also send them through the emergency room as rotations. So they get a nice experience in all these different areas, so that even if you don't know where you want to work as a nurse, eventually when you get done with the program, you've had a chance to experience all of those areas. As we finish talking about our simulation mannequin, there's one thing I realized that I didn't discuss about RNs and what their job opportunities are. A registered nurse, of course, learns the skills of what a CNA can do with these activities of daily living, of course, learning what the LVN roles as far as administering many medications. The registered nurse is the only one that can administer IV medications, and that's simply because of the deeper pathophysiology knowledge. But for registered nursing, we can, of course, go work in the hospital and take care of patients there. But there's a lot of opportunities outside of the hospital. We do have clinics. We have, you can go on and get your nurse practitioner degree. You can get your bachelor's and master's degree. You can work as a school nurse. You can work as a community health nurse with a public health license. You could even help eventually getting a forensic nursing. Your specialty could be a legal nurse. So there's many different avenues that registered nurses have the opportunity to work. It's not necessarily at the bedside, and of course that's a majority of where we work, but it's one of those things that you can work in different areas. And go ahead and pause.
To touch on a little bit more of what Kitty spoke about in regards to working in different areas, for an example, I've been a nurse over 30 years, and in my over 30 years of being a nurse, I've worked in multiple different areas. Sometimes at the same time, I have been one of those nurses that have had usually more than one job. But some of the areas that I worked in industrial health nursing, to where I actually worked in a cannery and took care of employees if they got sick or hurt on the job. I worked in a telemetry unit, to where actually we had heart monitors like this one, and I had to know a lot about the patient's heart. I worked in ICUs. I took care of open heart patients. I also worked in home health. I did that for 6 years, and I loved it. I went to people's homes and helped them with a lot of their health issues, and also I also helped them if they had needed meals, if they needed their medications. I connected them to the proper channels to get those things while they were at home. I took care of patients on a medical behavioral floor. I took care of that population. Consisted of mainly homeless patients, drug addicts, prostitutes, and those patients were very sick and they needed assistance while they were in the hospital, but they also had those behavioral issues as well. I did home hospice for a little bit, and I took care of patients as they were dying. In addition to, I also worked at probably about a year in a long-term care facility, short-term rehab, where that was those elderly patients that are in nursing homes. I currently work part-time in a cardiac rehab, so this is an area in which patients who have heart conditions come and they exercise being on a heart monitor, and we monitor them while they exercise. And then of course my main job here is working with students, teaching. That's it.
So just to tell you about my journey to becoming a nurse, when I graduated high school, I came out to Merced College and I was going to be an accountant one day. I came out here, took a lot of bookkeeping classes. I actually worked in loans and scholarships here at the college for a while. And then I had my children. I had my daughter first, and then 2 years later had my son. And when I was in the hospital after having my son, I just watched the nurse and I thought, oh my gosh, she has the most wonderful job in the world. It's all babies, and of course I had young babies, and so I just thought, this is what I want to do. I'm going to go back to school. And so I quit my job and of course was home with the kids, and I started taking the sciences. Anatomy was the first course I took back after being out of school for about 10 years. And I absolutely loved it. And so as I finished my nursing program, I was a licensed vocational nurse first, because that's what you had to do before you became an RN. We did not have the generic RN program. And I finished my LVN program, and I'm thinking, okay, I'm ready to go work. Where's those jobs in OB? And there was no openings, but I needed to go to work. So the job that I took was at Amberry Rehabilitation Hospital in Atwater. If anybody of you know the facility, it is definitely not about babies. It was the older generation, of course, because of course those are the patients that need assistance with their activities of daily living. I couldn't believe that I was going to work in long-term care with all these old people when I just wanted to work with babies. But there was a point, and I all of a sudden realized that this job was meant to be in this area. At that time, we had what we called respite care, kind of like relief for patients, families who were having to care for hospice patients, which of course means that they had a terminal diagnosis within 6 months, and they needed a lot of assistance with their care. And this was just to come in long enough to get a break from, let the family and the patient kind of, be able to, get that total 24-hour care, that they could, have somebody else to take care of it for a while. So this one woman, and not that I'm going to violate HIPAA, so the story is not exact, and I've changed some things about it, but she was there. She had been diagnosed with cancer, and of course it was terminal, and the pain wasn't being managed at home, so she needed to be in long-term care so that we could give her a pain pump that we could actually fill, the nurses could take care of. And she'd been with us for about 3 weeks, and that I worked night shift. She usually was in my section every time I worked. And I'd get done in the night, get ready to go home the next day, and I'd typically go in and tell my patients, okay, I'm gonna go home now and I'll see you tonight. And so as usual, I go in to tell this patient, and I said, okay, I'm going home. And she says to me, no, you can't go home, you have to stay. And it's like, hey, I gotta get my kids off to school, my husband's gotta go to work, don't worry, I'll be back tonight. And she says, no, I'm gonna die today and I want you here. And I'm just like, oh my goodness, wait a minute, what do I do? I mean, if she really thinks she's going to die, maybe, this is her time and she's gonna go. And I was like, but I gotta go home. And I said, I'll call back and check on you. And so all through, I could barely sleep once I got my kids off to school, because I kept calling to check on her. And she did well. She lived for another 3 days. And I happened to be on the final night that she was with us. And her family had come in. They were sitting on one side of the bed, and I was sitting on the opposite side of the bed. And we were watching her take her last breath. And it hit me at that point that as much as I thought, I'm going to be a nurse because I want to be there when a child enters the world and takes that first breath, that I realized when this patient took her last breath, how very special it was to be. And as a nurse, how blessed we are to be part of a life, right? So this is what I'll say about nursing. No matter where you work, we have the privilege of taking care of patients and making a difference in their life. And so if healthcare is somewhere where you think you want to be, I hope you explore those options. I hope one day you end up in our nursing program, whichever it is, CNA, LVN, or RN, because I think you'll find it's a very fulfilling and rewarding career. And so this takes care of our recorded portion, and we'll be switching over to where Dr. Schindler and I will be available to answer any questions.